Hello students, welcome to the discussion of the MCQs of some MCQs of a kidney and GIT which I have taken. These are some of the things to be discussed with you. First question says, 3-year-old boy comes with history of swelling on face. So there is presence of facial swelling. Mother gave history that he ate peanuts in party and it started after that. On examination, there is abdominal distension, bilateral scrotal swelling and pitting edema of his lower limbs. On urine, dipstick 4 plus protein and leukocyte is negative. Right? There is no leukocyturia. Renal function tests are normal and complements are normal. Most likely diagnosis is. Now first we say the 3-year-old boy comes with a history of swelling and face. Mother gave history that he ate peanuts in party and started after that. Now you might think this might be allergic reaction. There is nothing to suggest allergic reactions here. Right? If there has been an allergic reaction, there should have been given that there is some skin dermatological manifestation. This is the history which the patient usually makes, that basically it started after that. So therefore, acute allergic reaction to peanuts is totally unlikely. Now we are left with these three, and if you see here, the RFT, what we are saying is the renal function test, they are totally normal. Complements are normal. That means C3 level here is normal. So complements is normal, renal function test is normal. There is swelling which is being present and there is 4 plus proteinuria. There is 4 plus proteinuria, right? So if I take one by one, in hemolytic uremic syndrome, hemolytic uremic, so name is uremic, renal function test is not normal, and that usually follows a history of diarrhea or respiratory tract infection. That is not given here, so this rules out this. In acute glomerulonephritis, mostly secondary to PSGN, the complement level is decreased and it becomes normal in 6 to 8 weeks. It becomes normal in 6 to 8 weeks, but here given is complement normal, so this rules out this. So what is left is now the nephrotic syndrome, and it is most likely a case of minimal change disease because the age group here given is 3 years and the minimal change disease is mostly seen between 2 to 8 years of age, right? And the complement levels are normal, which is very well given here. And regarding the proteinuria, if we think of, in that we say more than 3.5 gram per 24 hour or more than 40 milligram per meter square per hour, or urinary protein to creatinine ratio. Urinary protein to creatinine ratio that is more than or equal to 2. Urinary protein to creatinine ratio that is more than or equal to 2. Right? So if you see here, out of the choices being given, the choices of nephrotic syndrome, and you need to remember what is the criteria of proteinuria. This is mostly what we use. Coming to the question number 2, 4-year-old child with nephrotic syndrome presents with fever, vomiting, severe abdominal pain, abdominal distension. Now there is fever to correlate that there is something infection going on, and that is something correlated to the abdomen. In blood test, there is peripheral leukocytosis with predominance of polymorphonuclear cell. Right? So if neutrophils are increased, along with there is fever, it has to be infection. On ascitic tap, there is polymorphonuclear cell more than 250. Most common organism causing this is. Now here we understand regarding the infections, regarding the complication which are seen in the nephrotic syndrome. So if we talk of the complication in the nephrotic syndrome, one basically is the increased incidence of infection. Increased incidence of infection. And then this is mainly due to loss of factor B in urine. Loss of factor B in urine. Right? Now one can say there is proteinuria, so there should also be loss of immunoglobulins. What infection we are seeing here in nephrotic syndrome, mostly it is by Streptococcus pneumoniae. Streptococcus pneumoniae more than E. coli and Streptococcus pneumoniae causes is the spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis, right? There is no increased incidence of cyanopulmonary infections which is seen in the immunoglobulin deficiency. For example, if you look X-linked A-gamma globulinemia of Bruton, you talk of severe combined immunodeficiency, common variable immunodeficiency, IgA deficiency, there is practically increase in the cyanopulmonary infection. So immunoglobulin deficiency is not the major cause of the increase in infection. It is the loss of factor B in urine which is the major cause of the increased incidence of infection here, right? Then how do you diagnose? You do the ascitic tap. If there is increase in the TLC count and neutrophils, you make a diagnosis, and after this what is to be given? Streptococcus pneumoniae, you basically start with the third generation cephalosporin. So the treatment here will be regarding the third generation cephalosporin, and the right answer to this will be the Streptococcus pneumoniae. Streptococcus pneumoniae. Question number 3. Child having nephrotic syndrome was given steroids for 6 weeks. Even after 6 weeks, proteinuria is persisting. Such a child should now be managed with. According to the latest definition of steroid-resistant nephrotic syndrome, according to the article in 2021, what we say, steroid-resistant nephrotic syndrome is proteinuria persisting even after 6 weeks of steroid. It is not 4 or 8 weeks, now it is 6 weeks. So proteinuria is persisting even after 6 weeks. Then we say particularly it is the steroid resistant nephrotic syndrome. It is the steroid resistant nephrotic syndrome. How we are going to manage? This is what we say, steroid resistant nephrotic syndrome. 6 weeks of steroid therapy, no response, go for a renal biopsy to find out what is the cause. Then you should start with the calcineurin inhibitors, and if both are given in the choice, tacrolimus more than cyclosporin. Tacrolimus more than cyclosporin, right? And if it is unavailable, you go for the intravenous cyclophosphamide. But if there is no response for 6 months to calcineurin inhibitors, then rituximab or mycophenolate, right? Now, what can be the potential question? Calcineurin inhibitor resistant nephrotic syndrome is how long? And that can be if you don't get response for the 6 months. That can be the potential question. If there is no response for the 6 months to calcineurin inhibitors, it will be called as calcineurin inhibitor resistant nephrotic syndrome. Okay, so according to the latest guidelines, now we say it is these 6 weeks. A question from the GIT. 2-year-old has history of diarrhea for the last 3 months. He produces up to 4 stools a day which are loose, brown in color and usually contains undigested food. Rest of our family is normal. On examination, child is normal and is growing on the 50th centile. Most likely diagnosis is. Most likely we are saying here is. Right? Now, if you say the child is normal, growing well, in a celiac disease, not possible. In a celiac disease, the growth is hampered, so this rules out the celiac disease. Cow's milk protein allergy, there is diarrhea, and plus there is usually loss of blood in stool, which is not mentioned here. So therefore, this also rules out this. Lactose intolerance. They are saying is it contains undigested food. Maybe this, but this lactose intolerance will not present at 2 years. It will very well present right at the birth if there is lactase deficiency. Clear? So this is something which is a case of chronic non-specific diarrhea, and we are saying the child is growing normal. Child is growing normal, and this can very well be due to the increased amount of fruit juices or less amount of fibers in the diet, that there is chronic non-specific diarrheas which are there. Right? So just by the method of exclusion, I am saying here the answer is chronic non-specific diarrheas. 12-year-old comes with the complaint of gradual loss of vision. There is ataxia intention tremors, loss of vibration and position sense. There is history of chronic diarrhea with passage of bulky frothy stools. This comes the line, bulky frothy. Frothy means fat. His plasma cholesterol is very low, serum triglycerides are very low. Most likely diagnosis is, it is most likely a case of fat malabsorption. Fat malabsorption, and out of this it can be Abetalipoproteinemia. In Abetalipoproteinemia, there is defect in the microsomal triglyceride transfer protein. Microsomal triglyceride transfer protein, and the fat is not digested. If the fat is not digested, what will happen? The fat will go in the stool, so there is bulky frothy stool. Then there can be absence of fat soluble vitamins, so there can be absence of vitamin A, D, E and K. So there can be absent. Gradual loss of vision given can be explained with vitamin A. Ataxia, intention tremors, loss of position and vibration, all are the features of vitamin E deficiency. Vitamin E deficiency as such is very rare, but it can very well be seen in Abetalipoproteinemia, and in this, on the particular peripheral blood film, there will also be presence of acanthocytes. There will be RBCs with spikes or spicules which are unevenly sized and unevenly spaced. So there can very well be presence of the acanthocytes. Right. So in this short video, I tried to cover the important questions related to the kidney and GIT. Thank you so much.